Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, ESCMID's open access journal covering infectious diseases and clinical microbiology. I'm Emily McDonald. I'm a physician in general internal medicine, an infectious disease trialist and scientist at McGill University in Montreal, Canada, and associate editor at CMI Communications. The new WHO meningitis guideline is featured on today's podcast, and we are excited to welcome three global leaders in the field. We'll be discussing how the WHO meningitis guideline came about, what went into making the guideline behind the scenes, why it was needed, and some of the key take-home messages for clinicians in both developed and developing countries who treat patients with meningitis. I'm delighted to be co-hosting this episode with Marc Bonten, fellow editor at CMI Comms.
Hello, and besides editor at CMI Comms, I'm a clinical microbiologist and epidemiologist at the University Medical Center in Utrecht. We're thrilled to have as our guest Lorenzo Pezzoli and Nicolò Binello, both from the WHO. Lorenzo Pezzoli is a field epidemiologist and the team lead for meningitis and epidemic bacterial diseases at the WHO headquarters. Lorenzo is passionate about public health and has spent the past 2 decades working in diverse settings on outbreak preparedness, vaccination strategies, and epidemic response. His experience encompasses a wide range of outbreak-prone diseases, including meningitis, cholera, and other diseases affecting vulnerable populations. He currently leads WHO's efforts on defeating meningitis by 2030 roadmap with WHO's emergency program, supporting countries in strengthening preparedness and response to bacterial meningitis outbreaks. Nicolò Binello is a medical doctor and internal medicine specialist. He currently serves as a technical officer within the epidemic bacterial diseases team at the WHO headquarters. Before moving to Geneva, he worked as a clinician in resource-limited and emergency settings.
We're also joined today by Jacob Bodilsen. Jacob was a clinical associate professor, medical doctor and researcher from the Aalborg University in Denmark. His research focuses on CNS infections, and he is the chair of the ESCMID study group for infections of the brain.
Thanks for having me. Great to be here.
As our regular listeners know, we always start the podcast with an icebreaker. Today's icebreaker: what kind of activity do you regularly engage in for brain health? I'll go first. So I'm convinced that fatty fish, like the fatty belly of the tuna, salmon, mackerel, that all of these fishes make me smarter. So I regularly consume them, hopefully not to the point where I get too much mercury to undo the smart fish fat. So that is me. Marc, you can go next.
Yes, I also have a daily brain health activity, and that is my Sudoku in our national newspaper. It's kind of a well-known Sudoku. It seems not to be so easy, so I record my time. And I can clearly see that during the weekdays, it's easier than on the Saturday. But each time that I finish it, I think, well, not so bad, still no dementia yet. So that's what I do for my brain health. So now, Lorenzo, you're up next.
Thank you. Yeah, for me, that's a moving target, I would say. If you would have asked me a few years ago, I would have said photography. But anything that really takes you away from day-to-day distractions, especially these digital distractions, I think is the key. I really appreciated going for walks with my family without taking the phone or even just reading paper books. Actually, speaking of meningitis, I'm reading this book by Andrea Lanfrey, who is a meningitis survivor, who's the first double amputee who climbed Everest, and it's really an inspiring book.
Thank you, Lorenzo. Nicolò.
On my end, I'm a big wildlife enthusiast, so I unwind by watching animal documentaries or reading books on nature. And as funny as it may sound, I find there's something soothing about watching lions on the hunt or sharks cruising for the next meal. The only catch is that while watching all of these animals and how they interact with humans, I try not to think too hard about species spillover, because if I did, basically it would defeat the purpose of detaching from work and relaxing.
And Jacob?
I really like sports, so I play football or soccer every Tuesday night, and I feel like I'm 15 years old again, although it's somewhat humiliating. I'm not that good. And then Wednesday morning, I feel like I'm 90 years old. And then I slowly recover during the week. And next Tuesday, I'm off again. So that's my moment of zen, I guess.
Great activities, everyone. With that settled, let's get into the new WHO meningitis guideline.
Let's start with a little history about the guideline. For those of us who don't know, Lorenzo, can you tell us What made the WHO want to craft a meningitis guideline, and what did the process look like?
We work in the WHO emergency program. So from a medical emergency point of view, I don't think there's any disease that is scarier than bacterial meningitis. It is a disease that can strike anyone, anywhere in the world. The recent estimates say that it causes at least 1.6 million cases every year, including 240,000 deaths. So 1 out of 6 patients die, and 1 in 5 survivors live with long-term disabilities. It's a disease that literally affects all countries in the world, and so all WHO regions, if we want to speak in WHO terms. But highest burden is in the area of Africa known as the meningitis belt. This is an area of sub-Saharan Africa that stretches between Senegal to Ethiopia, where especially environmental climatic conditions, also socioeconomic conditions, are risk factors for the spread of bacterial meningitis. We're talking especially the climate conditions that cause regular sunstorms, which can damage upper airways and facilitate the spread of bacterial meningitis. And in those areas, especially in some core countries, we have been seeing regular epidemics that often coincide with the dry season, a period that starts roughly from January to until May, June. So we are at the tail end of the meningitis season. And we see these very large-scale epidemics that when they occur, they have the capacity to disrupt the healthcare system. It is with this goal in mind, especially to eliminate bacterial meningitis epidemics, that WHO in 2021 launched the Defeating Meningitis by 2030 roadmap. The goals are 3. First one is eliminate bacterial meningitis epidemics, which, as I said, regularly affect the meningitis belt, but not only. Reduce cases by 50% and death by 70% from vaccine-preventable bacterial meningitis, and reduce disability and improve quality of life after meningitis due to any cause. So the roadmap really focuses on meningitis of any cause, but the core is really the bacterial meningitis epidemics, but not only, also more broadly, any vaccine-preventable bacterial meningitis. When we're talking outbreaks, we especially think of 3 pathogens that cause these epidemics. First and foremost, meningococcus, so Neisseria meningitidis. This is really the main cause of epidemic meningitis. But then we have also Streptococcus pneumoniae, which causes epidemics. Streptococcus pneumoniae causes also epidemic meningitis, or to a lower extent. And Haemophilus influenzae, especially Haemophilus influenzae type B. Although this last one is not really, luckily, a big focus of our work, because thanks to an excellent immunization program, we rarely see epidemics of Haemophilus influenzae. One other vaccine-preventable bacterial meningitis cause is group B Streptococcus. This is not an epidemic-prone disease, but it is a pathogen that causes meningitis, especially in mother-to-child transmission in infants and preborn. Also for this one, WHO is in the final stages of launching a vaccination program. So those are the vaccine-preventable bacterial meningitis causes. And it is part of the roadmap that we have developed these new guidelines, because the roadmap focuses on 5 pillars. The first one is prevention and epidemic control. The second is diagnosis and treatment. Then we have disease surveillance, support and care for people affected by meningitis, and advocacy and engagement. So these 5 very interconnected pillars. And as part of the pillar on diagnosis and treatment, WHO and partners wanted to have a solid guideline to support countries in tackling bacterial meningitis, and starting, of course, with the patients and how we diagnose the meningitis, how we treat it, which are the first things to do when it comes to epidemic meningitis.
Thank you, Lorenzo. And Nicolò, can you tell us something about what went into the development of the guideline? Who was involved? What type of specialist? How long to finalize the guideline?
So these are the very first comprehensive WHO clinical guidelines on meningitis. They were finally published 2 months ago after nearly 3 years in development, so it's a long time coming. The guidelines include 37 recommendations, as well as hundreds of clinical remarks and implementation considerations. But before we dive in, I think it's important to clarify the scope of the document. These guidelines address acute onset, community-acquired meningitis in adults, adolescents, and children over 1 month of age. They do not cover meningitis in neonates. They do not cover hospital-acquired meningitis. They do not address subacute or chronic forms of meningitis, nor do they address non-infectious forms of meningitis. In the context of acute onset meningitis, they do provide recommendations for both bacterial and viral meningitis. In terms of target audience, the guidelines are intended for global use, including in resource-limited and emergency settings. They're primarily aimed at healthcare professionals and frontline clinicians, but they're also relevant for policymakers, national public health authorities, international organizations, and academic institutions. The document is structured around 3 main chapters: diagnosis, covering lab investigations and cranial imaging; treatment, antibiotic therapy, adjunctive treatment, and supportive care; and finally, management of sequelae, addressing long-term physical, neurological, and psychological complications of meningitis. Now, to the question of why this took so long, the timeline is largely due to the rigorous nature of the WHO guideline development process, which is a methodological approach involving several stages of development and a wide range of contributors, both internal and external to WHO. The process began with the establishment of a WHO steering group, which included technical experts from across headquarters and regional offices, which coordinated the entire process and determined the composition of the guideline development group, which is a multidisciplinary team of experts, including clinicians, infectious disease, internal medicine, neurologist specialists, but also researchers, policy experts, and individuals with lived experience from all over the world. 20 guideline questions were proposed by WHO, validated by the guideline development group, and they subsequently informed the systematic review process. So these reviews, 20 quantitative and 1 qualitative reviews, were conducted by 5 academic institutions over the following month. As you can see, this is a massive undertaking. And once all the evidence was retrieved and synthesized, the GDG was reconvened by WHO and presented with the evidence using the GRADE approach. The group of experts then formulated the recommendations and good practice statements, which form the core of the document. After that, the draft was circulated to an external review group, an additional body of experts serving as peer reviewers, and to the Guideline Review Committee, which is the WHO's internal body that ensures that the guidelines are aligned with established procedures and meet the highest standards. Only after passing all of these steps was the document ready for publication. So yes, it was a lengthy process, but a necessary one given the breadth of the topic and the potential impact, hopefully, of these guidelines.
Thanks, Nicolò, and thanks, Lorenzo. It's really interesting to hear how the guideline was put together and everyone who was involved. Given this is a guideline to help clinicians fundamentally better diagnose and treat meningitis, we're really pleased that Jacob is able to join us today to give us a clinical perspective and also a research perspective. Jacob, can you tell us some of the challenges that you faced personally in the diagnosis and treatment of meningitis?
Sure. Like Nicolò and Lorenzo nicely alluded to, this is a really rare but challenging infection. It has bacteria surrounding your brain, which makes you uneasy as a doctor, right? First of all, we know that we have to be really attentive towards getting the diagnostic and treatment algorithm right for managing the patients. You don't want to overlook this diagnosis, and you don't want to be the boy who cried wolf all the time either. So you have to get that kind of balance right when to suspect this. So I think working as a clinician and having conversations with colleagues and younger colleagues especially, I think the old saying, if you thought meningitis, you should almost always exclude it, right? I think that still holds true.
Classic, yep.
Yeah. So I think as a clinician, you get a very focused initial history, if it's possible, what's been going on just prior to hospitalization. Check for the classic signs like fever, neck stiffness, also mental status. If there are petechia, check every inch of the skin, the nail bed, the conjunctiva, the oral mucosa to see if there are any petechia. And then you decide really fast, do I need to go on with a lumbar puncture or can it be clearly ruled out? And then it differs a little bit from setting to setting. There are different contraindications to doing LPs with or without having brain imaging first. Do we get all the right microbiological specimens for diagnostics? Do we start antibiotics immediately and dexamethasone, or is the suspicion very low and the patient is clinically stable? You want to see what's going on with the diagnostics. What are the initial results? What about monitoring afterwards, searching for additional foci of infection? An important aspect is talking to family, explaining what's going on and what is the foreseeable future, but also leaving some hope for them because there's good grounds for having hope. So those are some of the issues that are pressing during initial management, I think.
Absolutely. It's such a challenging diagnosis to make. The test to diagnose it can be quite frightening. both for the patient and for healthcare workers to perform. I think this really provides important perspective for the clinical need for this guideline. I work in a tertiary care academic hospital, and so cases of meningitis are pretty rare. I have resources like interventional radiology who could perform a lumbar puncture if it's challenging, or have neurology on call. Where I work, lumbar punctures can be performed quickly and safely. When CNS imaging is needed, we obtain it rapidly. We've got access to a broad range of antibiotics, and resistance is relatively rare. And this is certainly not the case the world over. For a number of years, I would travel and work in Haiti, and it was an entirely different story. At that time, we had cases of suspected cryptococcus among young people with newly diagnosed or untreated HIV. And to get a CT scan, the patient would have had to travel by car for over an hour, and the CT scan didn't always work. We were often troubled by whether it was safe to perform a lumbar puncture in the absence of readily available diagnostics. We frequently had to initiate therapy without a firm diagnosis, which isn't great for stewardship. And it was really one of the most challenging diagnoses that we had to make and manage at Hôpital Saint-Nicolò. Nicolò, can you tell us what some of the key recommendations are with respect to the diagnosis of meningitis that are presented in the WHO guideline?
Probably should start off by saying that the guidelines do indicate in individuals with suspected acute meningitis, lumbar puncture should be performed as soon as possible, preferably before starting antibiotics, unless there are specific contraindications or reasons for referral. And I'm going to get to those reasons in a moment. But once CSF is collected, lumbar puncture is performed, microscopic appearance of the CSF should be inspected, and a number of initial tests are all strongly recommended by the guidelines, including glucose and total protein concentration, white blood cell count, and gram staining. All of these investigations have been shown to have varying sensitivity and specificity. We already knew that, actually, but none can confirm or rule out a diagnosis of meningitis when taken alone. So we did emphasize in the guidelines that an integrated approach to interpreting these CSF findings is indeed essential to reduce the risks associated with relying on individual tests, false positives, false negatives. The guidelines also indicate that in resource-limited settings, these initial CSF investigations should be widely accessible, including in peripheral health facilities. And where this is not possible, CSF samples should be collected and properly transported to higher-level labs. As in, the need for sample referral should not be used to defer CSF collection and lumbar puncture in the first place. The guidelines also highlighted that CSF culture remains the gold standard for diagnosing bacterial meningitis and should always be associated with antibiotic susceptibility testing to identify resistance profiles and tailor antibiotic therapy. CSF molecular testing is also strongly recommended for all suspected cases. However, because of the risk of false positives, PCR results should always be interpreted in the broader context of the clinical presentation, as Jacob mentioned, and other laboratory findings. Importantly, PCR is not meant to replace culture and antimicrobial susceptibility testing, but it needs to be performed in addition to them. Culture remains the gold standard for diagnosis. Now, we all know very well that lumbar puncture can be performed safely in most cases. That said, there are certain conditions that increase the risk of complications. The guidelines have identified certain absolute contraindications to the procedure, which include a skin or soft tissue infection close to the lumbar puncture site, hemodynamic or respiratory instability, and bleeding disorders. Also, lumbar puncture can increase the risk of brain herniation in selected patients with increased intracranial pressure, such as those with severe diffuse brain swelling or space-occupying lesions causing midline shift. To minimize the risk and the incidence of brain herniation, it's important to identify those patients where lumbar puncture should be deferred. These are the so-called relative contraindications to the procedure, identified based on very limited evidence, only one prospective study, and the group's knowledge and expertise. And these include patients with a coma or a Glasgow Coma scale less than 10, focal neurological signs, cranial nerve deficits, papilledema, new onset seizures as far as adults are concerned, and patients with a severe immunocompromised state. This is exactly where cranial imaging comes in. The guidelines make it very clear that cranial imaging should not be performed routinely in all suspected cases of acute meningitis. But at the same time, in settings where it is available and readily accessible, it should be performed and conducted prior to lumbar puncture. How about those settings where cranial imaging is not available or readily accessible, which is often the case in resource-limited environments? In these cases, the group strongly recommended the clinicians defer lumbar puncture until the reasons for deferral have fully resolved. If the reason for deferral cannot be resolved, then lumbar puncture should not be performed. The only exception is in people with advanced HIV disease and cryptococcal meningitis is suspected. In that case, lumbar puncture should still be performed. Finally, blood testing. I think this is really important because we often forget that the bacterial pathogens that are most commonly associated with meningitis are often responsible for bacteremia and/or sepsis. Therefore, the guidelines recommend obtaining blood cultures in all suspected cases of acute meningitis as soon as possible, preferably, again, before starting antibiotics. And similarly to CSF, blood culture and antibiotic susceptibility testing should then be used to tailor antibiotic therapy based on the isolated pathogen and its resistance profiles. The guidelines also try to address the differential diagnosis with cerebral malaria in malaria endemic areas. In these areas, a parasitological test should always be performed for any suspected case of cerebral malaria/acute meningitis, either microscopy or an RDT. A positive malaria test confirms malaria infection and requires anti-malaria treatment, but does not rule out the possibility of concurrent meningitis, especially in areas of stable transmission of malaria, where malaria may be asymptomatic or present with non-severe manifestations, including especially in older children and adults. Any delay in diagnostic investigations, including lumbar puncture deferral, cranial imaging, should not delay treatment initiation. That was made very clear in the guidelines. And even though the diagnostic yield of many of these CSF and blood tests is reduced after the initiation of antibiotics, they should still be performed. And again, a diagnostic test, including lumbar puncture, should be performed unless there are specific contraindications.
Now, Nicolò, do we have any quantitative analysis of how frequently there truly is a contraindication for lumbar puncture? My experience is, although some time ago, that even though the guideline strictly defines the contraindicators, they may be taken liberal in daily practice, leading to a delay in diagnostic procedures. Is there any quantitative data on how frequently this happens and how frequently that is inappropriate?
This is a very interesting topic. I think that for the purposes of the guideline development, this was not reviewed systematically, but I am aware of a couple of studies at least that do investigate prospectively how frequently lumbar puncture are deferred in favor of cranial imaging and whether or not they meet clinical guidelines. To the best of my knowledge, these studies have been performed in Europe. And even though we cannot necessarily generalize the findings from European countries to the rest of the world, cranial imaging is often performed prior to lumbar puncture, despite the fact that there may not be absolute or relative contraindications to lumbar puncture. What the guidelines say, again, is that it should not be performed routinely, only in selected cases, as part of the next steps of the guideline development process, which includes developing clinical tools and job aids that clinicians can refer to. We'll try to make it as clear as possible, try to emphasize the role of lumbar puncture and limit the role of cranial imaging in selected settings.
Thank you. Okay, that's very clear. Second question was for Jacob, as he was involved in a recently published study in which the role of CRP, not PCR, but CRP measurement in cerebrospinal fluid was evaluated. I looked at the guideline. It was not included in the guideline because there are probably not that many studies that looked at it before, but maybe Jacob could comment on that aspect for the diagnosis.
Well, thanks. I must pay tribute to Matthias Broer and Sabine Orley, who really did most of the work in that. We just provided some control samples. I think it was ingenious because it was just so simple. They looked for all these biomarkers, very advanced biomarkers, and the one that paid out was the very old and well-known CRP and just measured in the CSF, and it had some incremental value on top of CSF leukocytes, because it should always be, when we do these diagnostic accuracy studies, it should be, is there any incremental value, diagnostic value, that is clinically relevant? If we increase the AUC by 1 or 2% or percentage points, it's unlikely to pay out much in clinical practice. But here there seems to be some added benefit, I think, especially for that more troublesome group with a CSF leukocyte count of around 100 to 1,000, which are the ones where we may be in doubt sometimes. Is this bacterial meningitis or some other condition?
And sorry, I'm not familiar with the study. Was it that an elevated CRP was more specific for meningitis, or when the CRP was low, it helped to rule out?
Both sensitive and specific. It was very close to 100. Could I maybe circle back a little bit to the contraindications to lumbar puncture? I really appreciate the WHO guideline having this global perspective because, all countries have their own guidelines and versions of this. And I think it's mostly because the association between each of these proxies for a mass lesion with brain shift or severe generalized edema are just proxies, and they're really not well established in terms of predicting subsequent risks of herniation. And I think this is really important to talk about, the lack of robust data to support this. It's mostly based on case reports and case series, expert opinion, and clinical reasoning. But at times, it may lead to some unnecessary delays in treatment. And it's been shown countries that have the most contraindications to doing LP just straight away are the ones that have the longest time to LP, and sometimes also antibiotics. At least in Europe, when you think about bacterial meningitis in these patients, we only write in about 1 out of 13 to 1 out of 17. And the other mimics, they require the same kind of timely diagnosis and treatment as bacterial meningitis does. But I did wonder about allowing clinicians to proceed with a lumbar puncture eventually if brain imaging is not available.
Yes, obviously, this is a very complicated topic to address through a guideline, both because of the limited evidence available and because providing global guidance that is applicable to all settings is extremely complicated. What we try to do is outline a set of criteria that clinicians can use, but we also establish the one very important exception in that people with advanced HIV disease, where cryptomeningitis, for example, is suspected or sometimes even the most likely diagnosis, in those cases, lumbar puncture should still be performed. And that's a recommendation applicable where the prevalence of advanced HIV disease is particularly high. Also, the remark on coma or Glasgow Coma Scale less than 10, that one should be interpreted in the broader context, as in when bacterial meningitis is suspected. If a patient has Glasgow Coma Scale and fever in a malaria endemic area, the most likely diagnosis is malaria. For example, coma may resolve after a couple of days of IV artesunate, and in that case, navigating these clinical challenges by deferring lumbar puncture, establishing a diagnosis of malaria, and then take it from there as to the next steps might also be something that is feasible in a low resource setting. Again, going back to the main point, yes, we provided a list to facilitate the clinical work on the front line, but there are exceptions, and it will obviously be up to the clinician treating the patient to make those decisions. By the way, one of the reasons why we listed these criteria is because sometimes in the field, in resource-limited settings, clinicians treating patients with meningitis do not have specialized skills. They're not infectious disease specialists. They may be just general practitioners, may not have been exposed to a lot of meningitis patients so far or the adequate skills. So by doing this, we hope to provide some kind of reference that they can go to as needed.
Yeah, I think we completely appreciate that. One thing that some listeners might be thinking is, okay, you can do the lumbar puncture if you suspect cryptococcal meningitis. That would be an exception if you're not able to get CNS imaging. Maybe we could mention now that some places that have access to cryptococcal antigen in the serum, that could be quite helpful because that's fairly sensitive and specific. Because for those who were wondering, well, how do I know if they have cryptococcal meningitis if I can't do the lumbar puncture? This is one of the cases where the serum testing is fairly accessible. I'd love to move on to treatment now, unless there's any other thoughts about diagnostics, anything that we missed that you want to cover?
I was wondering about the advice against doing a lumbar puncture for diagnosis of bacterial meningitis in patients with suspected bleeding disorder. A lumbar puncture in patients with coagulopathy does carry a theoretical risk of spinal hematoma that may, in a worst-case scenario, lead to inferior paraparesis. However, observational studies suggest that this risk is very low, likely below 0.2% or so. Could you please comment on what you mean about bleeding disorder and how it should be managed in this context?
Sure. That's another very interesting topic. So by way of background, the absolute contraindications for lumbar puncture procedure were not provided after a systematic review of the evidence, but they were based upon clinical and expert opinion. They're not part of the recommendations of the guideline. That said, the reason why it's not specified, it's on purpose. This is one of the scenarios where we leave it up to the clinician. Sometimes, while this may not be an absolute contraindication in high-income settings, a completely different scenario can be seen in low resource settings where patients with bacterial meningitis often access healthcare facilities at a very late stage. They may already have signs and symptoms of septic shock or disseminated intravascular coagulation without the possibility of being properly managed in that context where, again, frontline clinicians may not even be properly trained to perform lumbar puncture. Again, we did not want to specify a list of bleeding disorders to give some flexibility to the treating clinician to make their own decisions at the point of care. But again, as soon as evidence will be gathered on this topic more than currently available, we'll be happy to revisit this list, which was developed with a global perspective, trying to take into consideration different resource settings.
Yeah, it is why it's so interesting for us to talk about a guideline made by the WHO that does have a global perspective. We're very used to country level or region specific guidelines, considering how technically proficient the person is who's performing the lumbar puncture and whether they have the right equipment. Smaller needle versus a larger needle is entirely relevant. Let's move on to treatment. I think we should divide it up into treatment and adjunctive therapy. So let's start off with regular treatment. Are there some main updates to this guideline, new things that clinicians should be aware of?
We have tried to provide some guidance as to where meningitis patients should be managed, considering that bacterial meningitis is a medical emergency that requires prompt diagnosis. Referral comes with several logistical challenges in resource-limited settings. So the guidelines indicate that all suspected cases should be immediately admitted or urgently transferred to an appropriate healthcare facility, defined as a healthcare facility where lumbar puncture can be performed in the absence of contraindications and adequate monitoring and management of severe illness can be ensured. So this is the first broad management recommendation that we have. Sometimes we do have queries from countries as to where meningitis patients should be admitted. The answer is it depends on the capacity of that facility to manage that patient. Regarding antibiotics, again, considering meningitis a medical emergency, obviously IV empiric antibiotic therapy is recommended. When should antibiotics start? The simple answer is as early as possible, ideally within 1 hour of admission. And as mentioned earlier, delays in diagnostic tests should never delay the start of treatment. The approach is very straightforward so far, but what about those patients admitted to healthcare facilities that are not equipped for lumbar puncture performance or adequate management of severe illness? And this may be likely the case of a rural health center in a low-income country, for example. And during the epidemic season in the meningitis belt, a substantial proportion of these patients are seen in this type of facilities. These patients should be referred to an appropriate healthcare facility as soon as possible. And especially when a clinically significant delay in transfer is expected, pre-referral antibiotics should be considered. This is a conditional recommendation based on very low certainty of evidence. However, this is a huge change compared to previous practice. It's very similar to what's being used for severe malaria and was specifically designed to address operational challenges, feasibility concerns in resource-limited settings where referral systems may be suboptimal and a clinically significant delay in transfer may be expected by default. So in other words, empiric parenteral treatment is given before transfer as it may be beneficial, as long as acute bacterial meningitis is strongly suspected on epidemiological and clinical grounds. In these situations, both IV and when an IV line cannot be secured, IM administration of antibiotics are acceptable. When it comes to antibiotic regimens, obviously IV ceftriaxone or cefotaxime should form the backbone of treatment. If there are risk factors for listeria, age over 60, pregnancy, immunocompromised state, then IV ampicillin or amoxicillin should be added to the initial regimen. And in areas with a high prevalence of strep pneumo resistant to penicillins or third-generation cephalosporins, IV vancomycin should also be considered as part of the initial treatment. Finally, these guidelines strongly highlighted antibiotic regimens should always be reviewed and adjusted based on culture, based on antibiotic susceptibility testing results. And the goal here is to minimize the inappropriate use of broad-spectrum antibiotics and the emergence of drug-resistant strains. In terms of how long to treat, duration depends partly on the specific pathogen, and the document provides some guidance in that regard. But what happens when the pathogen is not identified and remains unknown? This may be the case in resource-limited environments, and we wanted to address this through a recommendation. In non-epidemic settings, stopping empiric antibiotics may be considered after 7 days, provided the person has fully recovered and has been stable for at least 48 hours. Final bit on outbreaks. How does treatment differ from non-epidemic settings? Well, during meningococcal and pneumococcal disease epidemics, IV ceftriaxone should be preferred over cefotaxime, mainly because it's more widely available and has a longer half-life that allows for 12-hourly administration. In meningococcal disease epidemics, suspected and probable case of meningitis should receive ceftriaxone for 5 days. In pneumococcal disease epidemics, recommended duration is longer, 10 days. The guidelines address potential operational challenges that may occur during outbreaks. For example, in the context of large-scale meningococcal disease epidemics, when a full 5-day regimen is not practical at all and health services are stretched to capacity, single-dose treatment protocols may still be used, but this should only happen when there's lab confirmation that the outbreak is actually caused by Neisseria meningitis, and the person can be reviewed after 24 and 48 hours, which might be problematic in some settings. So this is a summary of all the recommendations regarding antibiotics.
Yes, but also it's extremely challenging. In Western hospitals, you have everything available, but what if not? And if a patient needs to go on transfer for a lumbar puncture, you give the antibiotics, you can take a blood culture, but it will reduce your diagnostic yield. So the likelihood of identifying the correct pathogen and having the correct epidemiological information for your other measures reduces if you increase your therapeutic strategy by having antibiotics in or the corticosteroids. Either you say to all physicians in the lower middle income countries, get these antibiotics in first and then start thinking about sending a patient for a lumbar puncture, or send your patient for lumbar puncture first and wait with your antibiotics.
This is exactly what we have been trying to do very recently in Ghana this year and in Nigeria last year, where during the course of 2 different bacterial meningitis epidemics, one pneumococcal disease outbreak and one meningococcal disease outbreak, but basically we traveled across all these very rural primary healthcare facilities where you have very limited capacity to perform lumbar puncture, and referral or transfer to a first or second level hospital is likely to take hours, if not days. In these cases, we develop job aids pasted onto the walls of various healthcare facilities. If the patient meets certain criteria, sort of a case definition, then consider giving 1 shot of ceftriaxone and send the patient for further management. We're aware that this practice has tremendous implications in terms of AMR, and this is something that we're always very cognizant of. But the alternative for the individual management of this patient might be worse. This approach is very well known to frontline healthcare workers in low resource settings because they do exactly the same for malaria. You see a suspected or confirmed case of severe malaria, you give artesunate, and then you send the patient to a hospital or a high-level healthcare facility. Then same approach should be followed for meningitis, whereby if the delay in transport and referral is expected to be substantial, then in that case you give antibiotics and you send the patient for lumbar puncture. Once referred to an appropriate facility, physicians should still try their best to perform all sorts of CSF and blood investigations based on available resources, despite the diagnostic yield is reduced. This is another very common situation in resource-limited settings where patients may have received oral antibiotics before being seen in a healthcare facility. I think that developing very simplified clinical algorithms for managing these patients in peripheral health facilities is the way to go. We set the example in the meningitis belt, but it is also hopefully applicable in other resource-limited settings and even in humanitarian emergencies, by the way.
Yeah, and you mentioned in the role of AMR and the consequences of using ceftriaxone. That's always the moment that I want to quote Bruce Levin, who said, well, antibiotics do more than causing resistance. So should the fear of AMR be a consideration in the acute phase of this disease? I don't think so.
It's an interesting question, Marc. One other thing to consider is the reduced accuracy of the diagnosis isn't necessarily the same for molecular testing as it is for bacterial culture. So it is possible for the molecular tests to stay positive longer than the bacterial culture after the receipt of antibiotics. And so maybe as more people have access to molecular testing, we'll become less afraid we can give antibiotics because we know we could still make the diagnosis.
Yes, and the C-reactive protein will still be increased.
And if I can add that we don't want to encourage at all is to use antibiotics for those patients that present with non-severe clinical manifestations, and they may be considered suspected case of meningitis while in fact they're not. And this is another very common challenging across the meningitis belt, where antibiotics are often used for patients. And many of these patients are just uncomplicated malaria patients, or they might just have a viral self-limiting infection. So that's why I mentioned providing criteria, because even though you cannot encapsulate all the differences and all the nuances of meningitis by developing a list of criteria, at least that provides a reference for clinicians when it comes to deciding whether or not a third generation cephalosporin should be given.
I guess that also brings us to the fact that it's not just antibiotics that we're giving people before we've made the diagnosis. We're also now sometimes giving adjunctive therapies like dexamethasone. So I was wondering if you could speak a little bit about that.
In selected settings, adjuvant steroids can be given to individuals with acute bacterial meningitis in addition to antibiotics. Dexamethasone is the corticosteroid of choice. It might not be available in some resource-limited environments. In that case, hydrocortisone or methylprednisolone can be used instead at equivalent doses. So far, several guidelines have recommended steroids only in high-income countries or in high-income settings, leaving a gap for low- and middle-income countries, which these guidelines have tried to address through a systematic review that included 26 randomized controlled trials performed in high-resource and low-resource settings. In non-epidemic settings, when lumbar puncture can be performed, IV steroids should be started alongside the first dose of antibiotics in all suspected cases. This is a strong recommendation from the guidelines. But if CSF results are not consistent with bacterial meningitis, then steroids should be discontinued. When lumbar puncture cannot be done for whatever reason, either because it's contraindicated or because it's not possible to perform lumbar puncture, corticosteroids may still be given with the first antibiotic dose, provided that bacterial meningitis is strongly suspected and there are no contraindications to their use. And this is a conditional recommendation. In malaria endemic areas, one strong contraindication to the use of steroids is confirmed cases of cerebral malaria. So in those patients with a confirmed diagnosis of cerebral malaria, then steroids should not be used. I want to emphasize that these recommendations apply to both high-income and low- and middle-income countries, primarily based on the fact that there was no evidence in our systematic review of a difference in mortality between high-income countries and low-middle-income countries. There was some differences in terms of neurological complications, but in terms of mortality, there was no evidence in the subgroup analysis. During outbreaks, the situation changes. During meningococcal disease epidemics, which are the most common, IV steroids should not be routinely used in suspected or probable cases of meningococcal meningitis, primarily due to the lack of evidence suggesting a beneficial effect of steroids in individuals with confirmed meningococcal meningitis in terms of mortality and neurological complications. By contrast, during pneumococcal disease epidemics, steroids should be started with the first dose of antibiotics in all suspected and probable cases of pneumococcal meningitis. You can see that the recommendation of steroids changes based on epidemiological considerations. There are also recommendations on fluid management, osmotic therapy, treatment of seizures, and management of sequelae. Maybe I just provide a very brief summary. Fluid management, the guidelines provide a conditional recommendation against fluid restriction. So for maintenance fluids, preferred route is oral or through an enteric tube. If this is not possible, then isotonic IV solutions should be routinely used for maintenance purposes, meaning Ringer's lactate or normal saline. We wanted to make this very clear because of the widespread use of hypotonic or glucose-based solutions in low-resource settings, which are not indicated unless hypoglycemia is a concurrent concern. Increased intracranial pressure is a well-known life-threatening complication of meningitis and a true medical emergency, which may require osmotic therapy. It's important to note that the glycerol should not be used routinely as adjunctive therapy in patients with bacterial meningitis. The guidelines indicate that mannitol or sometimes hypertonic saline may be used as a temporary measure to lower intracranial pressure alongside all the other treatments. Regarding seizures, in someone with meningitis, the decision to start anti-seizure medication depends on a variety of clinical considerations, the person's overall clinical stability and the risk of having another seizure. What the guidelines say in this regard is that the length of anti-seizure medication should not be prolonged for more than 3 months, as long as no further seizures occur during that period of time. Finally, there are several recommendations on sequelae, which set the standards for the first time for the management of long-term complications. And they are very obvious in a way, but important to have in mind when developing control plans of meningitis. Individuals with acute meningitis from any cause should be reviewed for sequelae by a healthcare provider prior to discharge and at follow-up within 4 weeks. Same goes for audiological screening before discharge or after 4 weeks. Second, in those where one or more these complications are diagnosed, rehabilitation services should be provided as early as possible. And this includes hearing rehabilitation as needed. These are very obvious clinical considerations, but having them framed as recommendations hopefully will engage countries in providing those services as part of the package to manage patients with meningitis, including in resource-limited settings.
Thank you. It's a lot to consider. It is helpful to put it down in writing as recommendations because that can help hospitals set quality metrics, set some targets to attain. It must have been very humbling writing these guidelines, especially we see exactly where there is and also where there isn't evidence to support our practice. I was wondering if you could speak a little bit about what was missing in terms of the level of evidence and maybe particularly as it pertains to chemoprophylaxis, as that was a newer recommendation in the guideline.
So I think that strong and conditional recommendations in this guideline, as any other guideline from WHO, are based on variable levels of evidence, right? So under the grade approach that informs the guideline development process at WHO, evidence certainty is rated as high, moderate, low, or very low. Randomized controlled trials start off as high certainty, observational studies and non-randomized trials begin as low. From there, ratings can be further downgraded for factors like indirectness, imprecision, inconsistency, publication bias, and study limitations. So it's very difficult to actually have high certainty evidence for these recommendations. However, recommendations are formulated by taking into consideration other key domains, such as resource requirements, cost effectiveness, equity, feasibility, acceptability. All of these domains are incorporated into this decision making. Even in the presence of very low certainty evidence, the guideline development group decided on issuing strong recommendations. This is the case for chemoprophylaxis. Chemoprophylaxis for close contacts of cases of meningococcal disease with or without meningitis is well known. The guidelines recommend that the choice of the first-line antibiotic, either single-dose ceftriaxone or single-dose ciprofloxacin, be based on locally known resistance patterns and adjusted as needed, especially if the index case shows resistance on susceptibility testing. This is a crucial part of the recommendation as we're seeing increasing reports of ciprofloxacin-resistant strains in several parts of the world. In the presence of sporadic disease, antibiotic prophylaxis is strongly recommended for close contacts of laboratory-confirmed cases. And during large-scale epidemics of meningococcal disease, where lab confirmation can be resource-intensive and suboptimal, it is still strongly recommended to close contacts, this time of clinically suspected cases. And this marks a substantial shift from previous WHO recommendations, which advised against chemoprophylaxis during outbreaks in the meningitis belt. What changed here, the main supporting evidence came from a cluster randomized controlled trial conducted in rural Niger during a meningococcal disease outbreak. The trial showed that the effect of household-level prophylaxis with single-dose ciprofloxacin on preventing secondary cases was uncertain. But when Cipro was administered village-wide, a protective effect was observed. And in addition to all of this, individual-level protective effectiveness of 82% was demonstrated when comparing all people who received ciprofloxacin in both household and village-wide arms to those who did not. But this was the only study, and the group definitely did not want to formulate a recommendation for village-wide prophylaxis for global use. So the evidence was rated as very low, but despite this, the guideline development group still agreed to make a strong recommendation that applies across both outbreak and non-outbreak settings within and outside the meningitis belt, not just based on data, but also by taking into consideration feasibility and equity concerns, especially in low-resource settings. During a meningococcal disease outbreak, the primary control measure is a reactive vaccination campaign. But we all know that these campaigns can take several weeks to roll out. And that's why the guidelines highlight the need for additional control measures, such as chemoprophylaxis, to help bridge that gap.
Can I just comment on that and have a question? Here comes the AMR guy again. So there was over-concern of antimicrobial resistance with the treatment of individual patients, with a very strong recommendation that you can prevent mortality or sequela at the cost of a lower diagnostic yield. But here, the recommendation is to give ciprofloxacin to whole communities based on low evidence, based on feasibility and equity. And ciprofloxacin for a population definitely has consequences for AMR. So how is this AMR aspect incorporated in this recommendation?
This was the most important concern that was raised while formulating the recommendations. The middle ground that we found is to recommend chemoprophylaxis across settings to close contacts, not to entire communities. One may say that close contact in a rural village in Niger is indeed an entire community. But the definition of close contacts remains up to the country or to the local health authorities, because there is no way that we can provide a one-for-all definition of close contacts. That being said, the guidelines try to address AMR concerns, saying that the antibiotic should be based on whatever is known in terms of antibiotic resistance in that area, either in the community or at the individual level in the index case. If that is not known, which is often the case in some resource-limited settings, the guidelines are not too explicit because other considerations may be taken into account. We do our best to provide a recommendation that allows for implementation of chemoprophylaxis to control infection transmission across settings, but without necessarily promoting the indiscriminate use of ciprofloxacin or ceftriaxone. So basing public health decisions on known antibiotic resistance data is key here. And if they're not available, WHO encourages and strongly recommends generating that evidence in order to inform better public health response and mitigate the risk of antibiotic resistance. If new evidence is generated regarding ciprofloxacin resistance among the Neisseria meningitidis strains, and it probably will, WHO, I think, is able to reconsider these recommendations moving forward.
It's not the worry for the susceptibility of the Neisseria meningitidis for ciprofloxacin. It's more the whole gram-negative flora of the population being exposed to ciprofloxacin, what that will do for treatment of subsequent UTIs and urosepsis. But this is, of course, a very, very difficult thing. It really marks out a research agenda to answer that question.
Absolutely. And yes, AMR is really a horizontal topic. And when you have a vertical guideline, it becomes really difficult to use other considerations coming from other diseases, other infections, or even addressing the problem with the microbiota while formulating recommendations. So I think in this regard, all guidelines are not very fit for that. But we tried our best to address this while emphasizing the importance of generating evidence on antimicrobial resistance within the community.
I think what you mentioned, Nicolò, about how the WHO is open to new evidence on the topic is so important, because sometimes when you try to prove that there is equipoise, it can be hard if there's a guideline that strongly recommends something. So the fact that you've come out and very clearly stated that we made this strong recommendation, but it was based on a low level of evidence and we were open to new evidence and we could reverse this decision with new evidence is really important. Lorenzo, I think you were going to talk about the impact of this on infection control and controlling outbreaks.
So I think the aim of WHO is to bring any population, any person, wherever they live, to the highest standard of health. And in that respect, we were facing a landscape before where we had very clear recommendations of what to do when a meningitis case happens in a high-income setting, where you always provide chemoprophylaxis to interrupt transmissions. And in those settings, meningitis is a very rare disease. You may have one case because of waning immunization coverage, or not all the serogroups are covered in the same way by vaccines. And it almost never escalates into an outbreak. Maximum, you have a cluster in a very close setting. And then we had this other setting where we have these large-scale epidemics where the guidelines was a bit less prescriptive because we knew that it's not feasible. If you have these large-scale outbreaks, everybody becomes a close contact, and then you mass administer antibiotics, and we have the problems of AMR, the problems of not targeting the right people, and so on and so forth. Up to now, there was this dichotomy. What is the gold standard happening in high-income countries, and what was the reality in the outbreak settings? As we move forward towards eliminating meningitis, first of all, These epidemics still happen, but they happen less and less in the meningitis belt. Since 2010, we have introduced the conjugate vaccine against meningococcal meningitis A, which has effectively wiped out the major cause of epidemic meningitis, which was serogroup A. Now, since 2023, we have pre-qualified a pentavalent vaccine, so A, C, W, Y, and X, same technology, conjugate vaccine. Conjugate vaccines protect not only the individuals, but also from carriage. So it has a huge potential for herd immunity. By introducing that vaccine in the meningitis belt, we expect that the epidemiology of meningitis will be more similar to what we see in temperate climate settings or high-income settings. And there is where we can take the chemoprophylaxis one step forward with all the caveats, with all the interpretations, as we said, the need of evidence. We asked ourselves, why should the recommendation be different? If there is a possibility to provide a chemoprophylaxis to the close contacts, it should be our duty out of equity that no matter where you live, you should have access to these preventive tools. And that's our vision. It's the big difference from previous guidelines. And I feel a potentially game-changer recommendation. As we said, it's only the first step. We will need to work and support countries to adapt these guidelines to their context. As much as possible, reinforce holistically the AMR surveillance systems and the monitoring systems. But I think that if we wouldn't have started with this very strong recommendation, we would have not started in the right way. So I'm very optimistic that we are in good track with the roadmap to defeat meningitis by 2030. By the way, now it's 2025 and we are exactly at the midway of our roadmap, which was launched in 2021. And having these guidelines to accompany us for the next 5 years is something extremely exciting, and really appreciate the work that has gone into producing these evidence-based guidelines together with all the experts around the world.
It's inspiring, Lorenzo. I imagine, too, that one day we're living in a world where vaccination has eliminated the need for chemoprophylaxis, and that would remain a last resort if we can vaccinate enough of the population. To finish us up, Jacob, this is your bread and butter, doing research in infections of the brain. What are your take-homes from today in terms of what remains to be done? What are the next steps?
It was a joy and a real opportunity to listen to the discussion that was going on. I'd like to commend the WHO for performing this huge task and this comprehensive guideline, given all the lack of evidence and having to create a guideline that works for the entire world. I think to a large extent, the WHO has succeeded, and I was really happy to hear that they would be willing to reevaluate the evidence, of course, during the next couple of years. It's no secret that I think better studies on the diagnostic workflow is really important, using patients with suspected bacterial meningitis, not just confirmed bacterial meningitis. But better diagnostics for those with an unknown etiology, also maybe implementation studies of different algorithms, because different guidelines suggest different things. About 10 years ago, the discussion on hyperinflammatory versus hypoinflammatory meningitis, there are some animal studies suggesting to kill bacteria softly and then vice versa. So should we start slowly, or should we give even higher doses, like a very high first initial dose to get that concentration in the CSF right away? What about continuous treatment versus bolus? And then finally, we need to know more about these adjunctive immunomodulatory treatments, because we're left with corticosteroids, which we've been using for 70 years.
I completely agree. And the work that is currently ongoing is, as Nicolò already hinted, is the case definitions. Most of the time in those settings, the best you can do is, especially at the beginning, is have a strong clinical case definition to decide if you have a suspected bacterial meningitis outbreak or not. There are derivative product of the guidelines, and it's currently in publication. We have already revised the meningococcal disease case definitions with a group that is partly a guidance development group, so the GDG of our experts on the diagnosis, and a separate group within our roadmap, which is the surveillance working group. So it's kind of a collaboration between the clinicians and the epidemiologists to define what are the best suspected case definitions in order not to miss outbreaks and not to miss people who need the antibiotics, and at the same time not to overuse them. So it's a complex exercise, and it's really our priority after the publication of the guidelines. So meningococcal case definitions are in publication. I think Nicolò is leading that project. And the next one he will sink his teeth in is the pneumococcal disease case definitions, which have additional complexities because, of course, pneumococcus is not necessarily typically only a meningitis type of disease, but has many other presentations. So this is our work for the next months.
It sounds exciting, and thanks for those final words, Lorenzo. So I really want to thank Lorenzo and Nicolò for sitting in the hot seat and answering our tough clinical questions on the new WHO meningitis guidelines. Jacob, it was really great to have you round out the discussion with the clinical and the research perspective, and Marc for bringing up the issues with AMR. Thank you to our listeners for listening to Communicable, the CMI Comms podcast. This episode was hosted by Marc Bonten and me, Emily McDonald, editors at CMI Comms, ESCMID's open access journal. It was edited by Katie Hostetler and peer-reviewed by Dr. Liljana Lucic of University Hospital for Infectious Diseases in Zagreb, Croatia. Theme music was composed and conducted by Joseph McDade, and the executive producer of Communicable is Angela Hettner.